first set of slides, please. We're just waiting a second for our AV. Oh, there it is, right there. All right. Well, thank you, everybody, for coming this morning. I think we'll get started to stay on time so you could get to the beach in your snorkel gear, right? At the end of today's program, thank you for staying for the very last session of the last day of Congress. We appreciate your attendance, and we're so pleased and proud to present to you today the updated new family-centered care guidelines for SCCM, ACCM. We're going to vary a little tiny bit from your outlines, your printed syllabus today, because when we first submitted the program, our work was under embargo. It had not been released yet. So now today we will talk to you directly about the guidelines and their content. So I'd like to first recognize that there was a group of 29 authors on these guidelines and recognize the work of the entire team, even though only 4 of us would be able to present to you today. The writing team was selected from all age groups of practitioners, so neonatal, adult, and pediatric practitioners, with a balanced group from around the world so that we can, for the first time, approach this from an international perspective. And they were published in last month's Critical Care Medicine. Dan couldn't be with us today, so I'll moderate for the group. Actually, we'll each just introduce ourselves as we move forward to kind of keep this really timely. So I'm Judy Davidson, Dr. Judy Davidson from UC San Diego Health, and co-led this project with Dr. Randy Curtis. So Rebecca will talk to us. I will present the guidelines as they were developed and what's different kind of in the way we developed the guidelines between the last set published in 2007 and this new one today. Rebecca will then go into the actual recommendations and what was carried over from last time versus what you can expect to be brand new and different and unique. David Wang from Yale New Haven is going to be speaking about work tools that we developed simultaneously to the development of the guideline in 2 parallel coordinated structures so that you have your translation tools right now readily available through SCCM to help you guide change in practice in your own units and organizations. And then Dr. Randy Curtis will conclude today's panel with what we know we don't know, moving into all of the research we need to further the practice of family-centered care. Okay, so, and then hopefully have a couple of minutes for questions and answers. And the entire writing team for the guidelines has agreed that this slide set will become available to you. I've already talked to the people at ICU Liberation, and we'll be submitting this entire slide set for them to post to the Liberation site in case you'd like to use it for educating your own people back home. You feel free to do that later. And I always include my email on every slide set, so of course contact me and we can get you any other collateral materials you might need to help speed up translation of these recommendations into practice. I was asked to provide a disclosure slide. I have no financial disclosures to disclose, but I do disclose that I enjoy hand quilting and hiking with my dog. Okay, and I've quilted on every continent. I think I'm the only female to have done that. I have not submitted it yet to the Guinness World Book of Records, and that was not with my dog. She would not have liked it in Antarctica. So I've already mentioned that our guideline group was an international group of authors. They were content experts. We did not consider intellectual expertise as a conflict when constructing these guidelines. We felt it was indeed necessary to have content expertise to develop the guidelines. As you know, some guideline teams are written by guideline writers that are not content experts. We did the opposite. We pulled together people with a huge amount of expertise in this field to work on developing the guidelines together. We also had the luxury and privilege, and now I think it's a necessity. I don't think this kind of work can be done without it any longer. A medical librarian. Medical librarians are often double mastered. You know, they're very specialized in their skills, and our librarian actually took the initiative to go to a 4-day conference on creating systematic reviews to refresh her knowledge in systematic review, and then secured an external mentor to make sure that for quality quality control, because when you have a large group of authors, you might have 10 doctors that can all quality control each other, 10 nurses that can quality control each other, but the librarian, poor soul, is all by herself. So she had an external mentor to quality control her work at the same time during the guidelines development, and we were also assigned a grade methodologist, Dr. Mark Nunnally, who quality controlled all of our work and made sure that we stayed true to the evidence analysis process. And then we all went through team training on how to do the evidence analysis at each stage of the process, so that we had the same thought bubble in our head about how to approach the evidence in the literature to get to the point of writing recommendations. So the new guidelines are a start over. It's not a patch, and it was not like, okay, what did we do last time and does that still work? We just started completely from scratch. Mary Wickline, our librarian, looked to see when the beginning of the evidence started appearing in the literature. So we took all of the literature from 1994. We did like a Web of Science map and figured that 1994 is when this topic started emerging in a meaningful manner in the literature, and took all the literature from that point forward and considered it. We used, as I said, a strict process of evidence analysis, and there were absolutely no consensus statements in the final document. All of the recommendations that you see in the guidelines are born from evidence, not 10 wise men sitting around a table saying, I think it should be done this way. Right? That's the way guidelines used to be done, not any longer. In fact, we had to follow the strict rules from CMSS on writing guidelines. So there's a guideline on writing guidelines that you have to follow to publish a guideline. All right? The new part about it is that we actually did involve direct feedback from patients and families during the course of the guideline writing process. We had, I think, somewhere between 24 and 27 survivors of critical illness and family members that helped at several points in the process quality control our work and make sure we were on the right track and not forgetting important concepts that they would have wanted seen in the guidelines. Then they also took and rank ordered the outcomes of interest, like if we do this to somebody, what outcome could we expect from that intervention? So we had a list of 24 outcomes, and they rank ordered them, we rank ordered them, and lo and behold, we were almost identical in how we saw things of importance. For instance, if an intervention would save a doctor time, is that as important as if the family member might not have post-traumatic stress later? Right? So the psychological outcomes were deemed more important than efficiencies. Okay, so that's what I mean about importance of outcomes. All right. So because we did not just go back to the original questions that we asked in the 2007 guidelines, there's many questions that are left unanswered that you might say, hey, how about this? How come you didn't mention that in the new guidelines? Well, that happens in guidelines development. You can't cover everything, otherwise it would be a book and not a 15-page manuscript, right? So for instance, pet therapy. In the original guideline, we made a recommendation for pet therapy. There was very scanty evidence about it, but no evidence of harm, and we came to the conclusion that we could endorse it. In this guideline, we didn't even approach it. We didn't look at it. So at the local level, if you want to consider pet therapy, you would go back to the evidence we had in 2007, look to see what has been published since, and then make your own local conclusion on that, because we did not. Okay. So about evidence-based practice, and I'm only going to spend a second on this. This is like a traditional model that I'm sure all of you have seen published by Sackett in 96 and 2000, where you see that evidence-based practice is more than just the scientific evidence. It also takes into account the clinical expertise and judgment of people, and then also patient preferences and values. So our goal for the guidelines was to call out best-known practices related to family-centered care, and to do that, we had to get patient preferences and values and clinician experience and judgment. I've already told you that we had some direct feedback from patients and families, but we also took a brand new, novel approach to figuring out these issues of values and judgment by looking at the qualitative literature. We took 6 whole months and hundreds of qualitative manuscripts and looked at them to cull out the values of patients and families and values of clinicians through the analysis of interviews, ethnography, phenomenology, all of the qualitative literature. So we honored the voice of the consumer by looking at the qualitative literature first, before even going to what questions are we going to ask of the quantitative literature, the experimental literature. This is another EBP model by Melnick and Schmidt. Okay, so as I said, we had patient survivor family validation. We did enroll them in an IRB process. I would definitely include patients and families in the future and future guidelines the way we did here, okay? But I don't think having it through an IRB approved process was necessary. Looking back, one of the only things I would change in the entire process that we utilized was that we probably could have done it without IRB approval and just had them part of the team instead of as informants through a research protocol. And they gave us phone or email feedback, and they, at 3 different points in time. First, they helped us with the definitions of family and family-centered care. Then they helped us with the creation of the important concepts that we were going to write PICO questions for. A PICO question is a question like a research question, a cousin to a research question that you ask of the quantitative evidence. So population, intervention, comparison, outcome. If we do this versus this, what makes the best outcome, okay? And they helped us with the ranking of the outcomes as I talked to you about earlier. We did make important changes based on their feedback. I wanted to show this just to show you that every tiny piece of the process of guideline development, we had process maps, and we followed the process map. We created the process map and followed the process map to guide us in the process at each step of the way. And Rebecca actually led the team on, we had little teams for each piece of the process, and Rebecca led the team on creating the definitions. And one thing I'd like to tell you about the definitions, we use the term family-centered care intentionally because the goal of this guideline is to focus purely on the family, not patient family-centered care, because that would have been too broad of a scope. Not that we don't believe in patient family-centered care, it's just that the scope of this product is different, focused on the family. And we did reach out intentionally to the LGBTQ community to make sure that the definitions that we created would meet the needs of these people. And the definition of family is defined by the patient, or in the case of minors or those without decision-making capacity, by their surrogates. In this context, the family may be related or unrelated to the patient. They are individuals who provide support and with whom the patient has a significant relationship. So it's very fitting here in Hawaii, because in Hawaii, the term is ohana, right? And it's the same exact thing, that it's more than just blood relatives. It's more than just your wife, right, or your husband. Family can be defined by the patient. Family-centered care is then an approach to healthcare that is respectful of and responsive to individual families' needs and values. I think I've already talked to you about the approach we use to use the qualitative literature to come up with important terms and topics, important outcomes. We validated that with real patients and families in real time, and then develop our PICO questions. Then we looked at, after we had our questions, we used over 200 quantitative manuscripts and analyzed, broke up into little teams, one team for each set of questions, and then at least 2 people would evaluate, do an independent analysis for every manuscript that we reviewed, loaded that into the grade worksheets, and then our methodologists reviewed our work to make sure that we were true to the grade process, and developed evidence summaries from the evidence surrounding each question, and then proposed recommendations if there was enough evidence to support a recommendation on that topic. Another process map about the use of qualitative literature. Now, at the end, we did have a couple of recommendations that were born from very low level of quantitative evidence. So what we did, again, this novel use of the qualitative literature, we went back to the interviews and qualitative literature and said, okay, we've only have 2 studies that support this recommendation. Does it match what we heard in the qualitative literature? So we went back and said, do the patients really value having spiritual consultation during hospitalization? So spirituality was one of them. and I believe the use of social service as a consult was another one. So it came up several times where there was only a couple of articles supporting the intervention, but we found evidence in the qualitative literature in the values of our patients and families to further support moving that recommendation forward. If we had found conflict, we may not have made those recommendations, but because the data all moved in the same direction, we created the recommendation. Then we had strict rules for voting, and it was anonymous voting, so the loudest voice didn't get the answer. It was by calculated mathematical decision-making, okay? And then in 3 years, we were able to, and this is a very short timeline for guideline development, we were able to come up with the 24 recommendations in 5 categories: family presence, family support, family communication, consultations and team, and about things we should do as an organization and how we should build our environments. So we are really proud to say that we've had 9 professional organizations endorse this work and come out with endorsement at the launch of this: the Institute for Patient Family-Centered Care, the World Federation of the Societies of Intensive and Critical Care Medicine, European Society, AACN, CHEST, the American Thoracic Society, the British Association of Critical Care Nurses, the Society of Critical Care Anesthesiologists, and Pediatric Cardiac Intensive Care Society. With that, I'm going to move the topic over to Rebecca, and we can bring up our second set of slides, and she will talk about the actual recommendations, what you're waiting for.
Such a pleasure to be here. Feel free to continue the applause to Judy afterwards, because she put an immense amount of time into this. Immense. And we are incredibly grateful. So, alrighty, you ready for the meat? Yeah, we're going to get in. What's in it? So I have no financial disclosures to make. I'm not going to reference anything crazy. And my grant support in the past and currently are from these organizations for my research work. And so I'm incredibly grateful. So these were the guidelines, 10 years ago, which, as Judy already mentioned, were expert opinion guidelines. And you'll see they had lots of wonderful things in them. And as Judy already said, we started from scratch. We started from flour. Sometimes it felt like we ground the wheat to make the flour. And then I think that was the qualitative section. But we really wanted to do justice to this important topic. So if you want to kind of compare, so in the 2004 guidelines, there were 41 recommendations across 10 different topics. In our current guidelines, we have 24 recommendations across 5, not necessarily because some of these other things weren't important. Part of this is because our guidelines right now are evidence-based, and there weren't studies on all of these topics. So some of these topics are really important if you want to go back and look at them. And certainly you can look at the literature that was used to inform those guidelines, and you can say, well, why didn't you do this? Like maybe pet therapy or some of the studies on shared decision-making that were advocated for, and there's just sometimes not evidence. So perhaps use it as a call to arms that this is maybe something that needs further research. So, 24 may seem less than 41, but it's still a lot. So let me boil things down a little bit so it's easier to comprehend. So we have 3 concepts that are stable over the years. They were there in 2004. They're here now. If they're not going on in your ICU, you may want to think about this a little bit, because there's good evidence to support them, and the evidence hasn't changed. So, and then we have 3 kind of boiled down concepts that are really the new data on the block. So the 3 things really stable over the years. Let me give you some hints to start out. So if this is your ICU team doing rounds and the family standing way over here, maybe reconsider that configuration. So family presence is something that's been studied and very much supported. It can be family presence at the bedside, so open visiting hours in the ICU, family presence on rounds, as well as family presence during resuscitation, so during CPR with a trained staff member. Please go back to the guidelines if you want to look at the data. These weren't because we all thought these were great topics and we think everybody should do it. No, there's actually that evidence supports that family members have better outcomes with this access to their loved ones. So if you have open and flexible visiting hours, you will have better family outcomes. If you have family presence on rounds, you will have better outcomes. Even family during resuscitation, which even at my own institution can be something that some providers feel very emotionally conflicted about, but there's actually evidence that if that's what families want to do, if they want to be present, that is actually, with a trained staff member present, can have better outcomes for them. Ready for hints for next round? Something related to this, maybe this, a little bit of this, not this. Communication. It's really important to communicate. And that's routine family conferences. Note that that's different than family presence on rounds. I always think of conferences as bi-directional. It's sharing information. That gets into remember the blah, 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 that was all one directional? It needs to be bi-directional. And, there's actually even structured approaches that can make that type of communication more effective. Things like, I'm having a brain hiccup. Vital Talk, Spikes, Ask, Tell, Ask. There's structured ways to have communication that have been studied that actually can improve the communication. And on that same note, which is like Vital Talk, communication or C3, or there's a number out there that you can that are referenced. But there's communication training that can go towards providers, and providers are providers. They are not one group or the other. There's good communication that benefits nurses, that benefits physicians, that benefits anyone who's interacting with patients in the ICU. So it's really a interprofessional aspiration. And so then the last thing is, something to do with teams. Who do you have on your team? Who's playing on your team? Do you have Mr. T on your team? Sometimes it feels like I have Mr. T sometimes on my team. But, who is doing this with you? With whom are you journeying? And are there certain folks to have on your team that can actually improve patient outcomes when you look at the evidence? And yes, there are. So Judy had already mentioned about spiritual support. That was present in the guidelines 10 years ago. It's present in the guidelines now. Please have chaplains involved or readily available. And then also, near and dear to my heart, palliative care consultation. And we're saying for selected populations, not because, oh my gosh, it's only good for those populations. This is where we have evidence. This is where we can say, palliative care is may be good for everybody, but this is where the evidence we have supports that consultation of palliative care specialists can improve family outcomes. And that's particularly important if you have limited resources. We know we have a bad workforce shortage with palliative care consultants, and also that good integrative palliative care is important in the ICU. There's a lot of palliative care that should be provided by the ICU team. But these are particular populations that we have evidence that probably consultant palliative care could improve the family outcomes. And that's advanced dementia, cerebral ischemia after CPR, prolonged ICU stay. Prolonged can have varying definitions dependent on the different studies, and subarachnoid hemorrhage requiring mechanical ventilation. So to kind of put it all together, these are the three big boiled down concepts that were stable over the years. They were there in 2004. They're still here in 2017. If you're not doing them in your ICU, maybe that's time for a soul-searching moment, or to bring together an interdisciplinary team to figure out what are the barriers at your institution for doing these approaches, because there's actually pretty good evidence that's been stable over the years that support that they improve family outcomes. So new data on the block. 3 concepts yet again. Remember, this is 23 concepts. I'm trying to boil it down so it's a little bit more digestible. So 3 big ones. First is family support, different ways to better support the family as they are journeying through their loved one's illness in the ICU, and I'm going to break that down further. Team was important before, still important. There's actually some other teams that we now have evidence that it might be good to involve. And then different operational environmental issues. And I boiled this down in the sense of what kind of environment are you creating for the families in your unit, as well as for the providers who are caring for the families in your unit. So as far as family support, so things like providing families with informational leaflets. Some of the best data from this is Eli Azalay's study, which is over 15 years old now, but that informational brochures actually can help family members. Family education programs, these can come in various different ilks, but there's good evidence that they can support, or there's evidence that they can support better family outcomes. ICU diaries, these I just find fascinating. And please, if this is something that interests you, go look at our guidelines, look at the literature that underlies this, because I feel like this is pretty low tech, but yet high potential benefit for families as well as patients, if you want to go to patient and family-centered care. And it's just fascinating to me to look at what some of these research groups did. I mean, some of them took pictures of the patient every day and put that in the ICU so that after critical illness, the patient could look back and say, that's what I looked like. And at least this is a description for some of the family members. They're like, yeah, that's exactly what you looked like, because you have patients who maybe minimized how sick they were and have blank spots in their brain as far as what went on during those times they were in the ICU. And those pictures or the written sections by clinicians or family members can actually fill those blank spots. You know, we don't have the evidence to say that's exactly how the benefits conferred, but it's really a fascinating topic, and I really find that interesting. And then we have specific data for neonatal ICUs. Family members be offered the option to assist with care. Not that this isn't good maybe in all ICUs, but the data we have is from neonatal ICUs. So if you're in NICUs, this would be a good thing to be doing. We have evidence that it supports family members. If you're not in NICUs and you think this probably is a good idea, go do a study so that next time we have guidelines, we can actually cite your work. And it can maybe take this out of neonatal ICUs. But the data is that it supports family members well in neonatal ICUs, as well as peer-to-peer support. Implementing programs where family members who had a loved one in the ICU can be available for those who have a loved one in the ICU now. So other teams to involve, we already talked about chaplaincy and palliative care. We still have fairly good evidence for involving ethics consultants, particularly for, quote, value-related conflict between families and ICU clinicians. This comes out of the literature from Larry Schneiderman and his group Anderex, the most recent article published on it, but bringing in ethics consultants to help with when there's conflicts in values for patients in the ICU, conflicts being between providers and family members. As well as there's evidence from neonatal ICUs about the benefits of cognitive behavioral therapy provided by psychologists. And then social workers, as Judy already mentioned, especially at family meetings. So bringing in social workers to help facilitate communication. And then another version of that is navigators, which certainly some of the most exciting data is from Randy's group. It was published a little over a year ago in the Blue Journal. But having navigators in the ICU and how that can help family members in coping and improve outcomes. And then what kind of environment, what kind of operational system are you building and having in the ICU to best support families? That can be physical things like actually family-centered care policies in your hospital. So you're not just saying, hey, this is what we think is good in our own unit or such, but hospital-wide is making a commitment. They've got skin in the game. They say family-centered care is important, and this is how they are doing it. It can be hospital policies about open visiting hours. There's a lot of different ways this can be taken, but really that C-suite organizational buy-in that this is important. Noise reduction protocols in private rooms are suggested, as well as providing family sleep surfaces. As much fun as it is to sleep in a chair that does not lie flat, that probably families will get better sleep and be doing better if they can actually have a sleep area or a sleep surface that works for them. And then specifically about the environment for nurses and that they can create for family members, particularly that nurses be involved in decision-making about goals of care, that's not just a physician-family discussion that has to involve nurses. The way I always phrase this when I'm teaching on it is, families don't make decisions if there are decisions to be made about goals of care, like flicking on and off a light switch. They may have that meeting with the providers, but that decision usually is made over hours to days, and who is at the bedside with them making that decision? It's usually not the intensivist. It's the bedside nurse, so you need to have the nurse available. Also, too, to help shelter the family, so when nudge the family to remind them about the content of the conversation. So, if they're going, gosh, he's doing so badly, we should do that lung transplant, and then the nurse saying, remember what Dr. Curtis said? I wish that it was possible, but he's not a transplant candidate, and the nurses need to be present at the meeting to know what was said to help facilitate that decision-making, which is going to go on beyond any of the conferences. as well as nurses be trained in family support, which is not the same exactly as communication training. There's a lot of communication in it, but also things like bereavement support and just being able to support the family, yet again, as they're journeying through this time of critical illness for their loved one. And then sedation and analgesia protocols, because I think particularly for nurses, it's very hard to look at a family and say, we will assure their comfort when you don't know what's going to be written and it varies by the provider. So if you have set protocols, so you know if they're uncomfortable, I'm going to do X, Y, Z, I've got Haldol for this, I've got Ativan for this is how we're going to titrate up narcotics for patients in pain. That creates a good environment to empower particularly your nurses to be able to follow those protocols and reassure the family that this is how we are doing it. This is how the sausage is getting made to make sure that your loved one is comfortable. So kind of summarizing it all, stable over the years, family presence, bedside, opening visiting hours, on rounds, during CPR with a trained staff member, communication, family conferences, structured communications and skills training, and then teams, chaplaincy and palliative care for certain populations, family support, things like leaflets, navigators, others, teams to involve, social workers, go to the guidelines. There's a lot, operational environmental issues, protocols for analgesia, sedation, good sleeping spaces, and noise-free environments. Those are the topics. And that's about it. So thank you so much, and thanks for being interested in our guidelines. And next coming up is David Huang from Yale, who's going to talk to you about the tools that exist online so that you can better operationalize these as soon as you get home.
Thanks so much, Rebecca. Good morning again to everyone. It's a pleasure to have a chance to present to you guys. As Rebecca mentioned, for the next 10 minutes or so, it's my pleasure to present to you some available work tools that we've developed with these guidelines to support family-centered care. And before launching into it, I just wanted to just acknowledge up front these projects I'm about to tell you about were a collaboration between the Patient and Family Support Committee of this organization and the Guidelines Writing Group. And I just wanted to say on behalf of on the committee, I see Kim and Barb here as well. Just wanted to say on behalf of the committee, we wanted to say thank you to the Guidelines Committee for involving us. We really had a blast working on this together. Just to set the scene for these next 10 minutes. So you've heard a little bit from Judy about the tremendous amount of work that went into putting the guidelines together. We heard from Rebecca some of the content changes in the guidelines from the last set and from 2007. And the hope is that at this point in the presentation, some of you may be wondering yourself, well, what now, right? So the guidelines are there. They're fantastically researched, but then all of us who go back to leave Hawaii and go back to reality in our own ICUs have to fend with the question of exactly how to implement these guidelines. And that can be a difficult thing. We all know that organizational change is difficult. And the purpose of the next 10 minutes is just to share with you some tools that have been developed to hopefully make that process just slightly easier. These are my disclosures. So to talk about the learning objectives for the next 10 minutes, there's really just two. So I hope that you're going to be able to leave this session and number one, be able to describe a free gap analysis tool that helps ICUs prioritize family-centered care recommendations to target first at your individual institution. And number two, I hope that you're going to be able to identify a list of available resources that's available with the guidelines that can help your ICU with implementing the recommendations themselves. So we talked a little bit about Judy had mentioned up front that these implementation tools were developed in conjunction with the guidelines, and if you've heard already, there's 24 recommendations. They're in 5 different domains. That's a lot of different recommendations for each of us here to grapple with in our local institutions. And so I just want to start with the question of how that we're probably all wondering, how should your local ICU go about changing your current practice to reflect the guidelines? So you go back to your local institution. What's the game plan now that you have these 24 recommendations in hand? Well, the purpose of this first tool that I'm going to tell you about is to try to help you identify the major gaps in your particular ICU. And so, hopefully your ICU may be already adhering to some of the FCC recommendations, as Rebecca mentioned. A number of them are unchanged from the 2007 set of guidelines. But I think if we're all honest with ourselves, I imagine, especially with the folks in this room, we all realize that many of these recommendations are not ones that we are already doing and that will take a significant amount of work to implement. And I think to do that successfully, prioritizing those recommendations that are not only important but are actually feasible, as we think about low-hanging fruit in our own institutions that we can target first, that's a key strategy for early success in getting things off the ground. So this first tool, this gap analysis tool, I just want to share. What is it? So it's a free tool. It's a questionnaire, and it evaluates your practice, your ICU's practice, against the recommended practice that we just heard from Rebecca. The purpose of the questionnaire is that you take it and it creates a priority list for change. And it has sections to it that allow you to reflect on how to assess the barriers to change at your particular institution. And at the end of it, it develops a feasible organization-specific bundle to enhance family-centered care in your particular ICU, something that's tailored to your particular ICU's needs. So just nuts and bolts, so how do you get it? How do you get this tool, right? So actually, before I worked on this, if you had asked me how to actually find the guidelines on the SCCM website, I probably couldn't have told you up front. But just to make it crystal clear, you go to sccm.org, and under the research and quality section, that's actually how the guidelines are accessed on that front page. You then get brought to this splash page where you can see the guidelines online here. And if you click on this, you'll see a whole list of all the different guidelines that SCCM has put out before. And under the clinical section, you'll see the most recent these most recent guidelines for family-centered care that we're here to listen to about. But directly underneath it, we've put the implementation tools right on that page, right where you would get the PDF for the guidelines. So there's 3 different implementation tools that are here, or 2 different tools that are here. We're going to talk about this gap analysis tool first. If you just click on the link, it downloads as a zip file, and you can open the Excel questionnaire. And the second link that's beneath it is actually a YouTube video that's about 5 minutes long that basically spells out step by step how you can use the Excel questionnaire so that there isn't any confusion. And we'll talk later about the implementation tools. So for the gap analysis tool, this is actually it's 2 worksheets on an Excel spreadsheet, and this is what the first worksheet actually looks like. So step 1, gap analysis questions. What you see here. You'll see that the 24 different items or recommendations in the guidelines, and each recommendation paraphrased. They're grouped by the different domains that you already heard about from Judy and Rebecca. And as Judy had mentioned up front, the writers of the guidelines had put quite a bit of thought into the different types of outcomes that each of these different recommendations affect. So, for example, as Judy had mentioned, recommendations that target things like post-traumatic stress disorder and families down the road were deemed as having higher outcome than, say, things that just save physicians' time. And so based on that, our work group assigned a certain number of points to each of these different recommendations, basically to weight them in the questionnaire. And all you have to do when you're taking the questionnaire is to look under this frequency column, and you'll see that each of these boxes, there's a drop-down menu. And you can basically rate how often your organization is already adhering to this guideline. So, for example, for recommendation number 1 here, nearly always, recommendation 2, nearly never, and so on. In the spreadsheet, once you take the questionnaire, it takes about only 15 minutes or so when we've tested it. It automatically populates this item score that's here in this column. It's a scaled score from 0 to 50. And the most important thing is that it actually automatically auto-populates and ranks the different recommendations. So the ranking is based on how infrequently, so things that you're already doing infrequently, but that also have high impact or have important outcomes are the things that rise to the top of the list. Once you take this first part, you'll switch. There's a second worksheet that, again, is auto-populated. So it takes all the information that you filled out over that 15 minutes, and it ranks them automatically, prints them out for you with the item score from 0 to 50. And what it does is it takes the top 5, recommendations based on score, so that basically you're presented with the bundle recommendations that the spreadsheet would recommend that you target first at your institution. And then after that, there's a few questions that are built into the spreadsheet that you can print out and use to run, say, like ICU organizational meetings at your local environment. And the questions that they frame the discussion around are, number 1, how does your ICU differ from each recommendation? So specifically, what are you doing right now, and how is that different from the recommendation that's there? What are the barriers to implementing the guideline recommendation as you think about what's feasible and not feasible? And then it asks you at the end to re-rank those top 5 recommendations in order of the priority that you think would be best for you to attack at your own institution. And so hopefully, of course, figuring out the gaps is just the tip of the iceberg, but hopefully this tool will just make it just slightly easier, that much easier to figure out a game plan at your institution as you leave Hawaii and think about how to implement change. Just to spend a few minutes on the second tool that I want to discuss, so addressing your gaps, right? So you've identified your gaps. So what's the next step? So awareness of resources that already exist, that's key for efficient implementation, right? So imagine a lot of us are doing, hopefully, similar things at our institutions try to help families. But the idea behind this particular tool is that we all have limited time and resources, and the idea was to try not to reinvent the wheel when there are resources already out there, free or easily available on the internet that can really save you a lot of time from folks that have thought a lot about these things. To help implement change at your institutions. And so I just wanted to mention that the guidelines themselves, there's actually a 9-page appendix to the guidelines that's labeled a work tools list. And the whole idea behind this list of resources is to help implement change at your local institution. So I'll show you just a sample, but the resources on this list for each recommendation, they're listed, again, in the 5 different domains, categorized the same way in the recommendations, and each of them are listed with web links in the document so that it makes it a little bit easier for you in terms of accessing things that might be of interest for your particular bundle. So how do you find this work tools list? It's very simple. It's actually linked inside the PDF in the critical care medicine document. So if you actually have the guidelines in PDF form, you just go to the work tools section. There's actually a link that you can just click on that goes directly to the supplement if you're connected to the internet. It's also available on the guidelines page, as I showed you earlier. And just to give you an idea, we don't have time, the goal of this is not to go through all 9 pages of different resources that are available, but just to give you a feel for what this might look like. So for example, category 1, the first recommendation, is about family presence that Rebecca talked about. And what's listed there are a few different resources that have come out, in the past 10 years or so that may help you as you start to think about how exactly am I going to get families at the bedside with regards to resuscitation or in rounds, right? So this is in particular about open visitation. The AACN has put out a practice alert that has some documentation and helpful literature. And then the Institute for Patient and Family-Centered Care, which had been mentioned earlier, actually put out a big campaign called Better Together Partnering Families, which includes a free change package on their website to help you facilitate 24/7 visitation of your unit if that's a goal that you're trying to achieve. So for each of the different 24 recommendations, there are lists here. You can see they're listed with the cost, that they cost, and then also an easy link here that you can click on that takes you to the resource. So that's basically it. I just wanted to mention that these tools are also linked. For those of you that are familiar with the ICU Liberation Initiative, all the tools are available under the F, the ABCDEF. F stands for family. On the F portion of that website, the different tools are listed there as well. And so our hope is that these different tools will be helpful to each of you as you go back to your institutions and think and grapple with how to actually implement the guidelines with your colleagues and with your families. So with that, I just want to say thanks. As I mentioned up front, this was a collaborative effort between the guidelines writing group and several members of the patient and family support committee here. And I just wanted to say a special thanks. He's not here, but there was a bioinformatics expert at Judy's institution, UCSD, named Robert Alcara, who is totally vital in terms of programming the spreadsheet to make it automated, and we're indebted to him for his help. So I hope that these tools are helpful, and I just wanted to say thank you for your time. Dr. Curtis will come up now and talk a little bit about research from here.
Great, thanks very much. I just wanted to start my comments by saying that for me, it's probably the 3rd or 4th guideline that I've been involved in my career. And these tools that David and his group have built is a really exciting advance. In the past, we simply put all the guidelines together, published them, and put them out there for people to use or not, and I think the or not was more common. I really encourage people to try using these tools and to give us feedback about how to make the tools more relevant. Well, I was asked to talk a little bit about future research. I'm going to we're running a little long. I want to make sure there's a little bit of time for questions, so I'm going to go through this kind of quickly. I have no financial conflicts of interest to disclose. I have funding from our healthcare system, the Cambia Health Foundation, and federal agencies as well for the research that we do. And what I thought I would do is quickly talk a little bit about what these guidelines tell us about the need for future research. Why do we need research about supporting family members? If we believe it's important, maybe we should just do it. Maybe we don't need research. And then particularly what outcomes should we use, and what outcomes do we need? The grade system that was used by our guidelines group is probably fairly well known to most of you. You actually rate both the strength of the recommendation and the strength of the evidence. And I think it's important to point out, as the previous speakers have, that we don't have any strong recommendations in these guidelines. And we didn't rate any of the evidence as being strong. And I think that speaks to the importance of additional research in this area. I think we've highlighted the research that has been done and the evidence upon which you can start to implement in practice. But I think we need a lot more research. There may be other tools that are equally or more effective that need to be studied. This shows you a list of the citations that we pulled, that our librarian pulled on family-centered care. And you can see that this is really taken off. There's a lot of publications recently. We decided, based on this, to collect our data starting in 1994. But I think because this is a rapidly developing area of research, it is also a relatively immature science. And I think that we need a lot more work done in the outcomes and evaluation of potential interventions. I apparently can't count. I counted 23 recommendations. There are actually 24. But this just shows you that there were only 2, and I believe this is correct, that were moderate strength evidence, 12 low quality, and I think there were actually 10 that were very low quality. You've already heard about the importance of support for family members. That's where our moderate level of evidence was, and the other domains, the evidence was either low or very low quality. And I think that this highlights these important targets for future research. In the document itself, after each of the recommendations, is a suggestion for research. And so if you're interested in topics for research, I think it's worth looking at those. I put up a couple of examples here that I won't read, but just showing you that we identified specific areas of research to move things forward. We also created an electronic appendix. It's Appendix D, that has 33 specific recommendations for areas of research as well. And if you're interested in research in this area, I would encourage you to look at those. So I think, given the evidence is weak, and given that if you're here, you probably have bought into the idea that family-centered care is extremely important, do we really need evidence? And I want to highlight a couple of recent studies that I think point to the importance of having robust evidence. The first is this randomized trial published in JAMA this past year. And this was a study that looked at the effect of palliative care-led family meetings in an ICU setting for patients with chronic critical illness. It was a very well done randomized trial using 4 medical ICUs. They enrolled over 250 patients and over 350 family members. The trigger for instituting this intervention was a chronic critical illness, which they defined as more than 7 days of mechanical ventilation. The intervention itself was to have a palliative care specialist lead 1 or 2 family meetings. But this is not, repeat, not a palliative care consult. At least it's not the way palliative care consults are done in my hospital and probably most of your hospitals. And in fact, the ICU physicians were only present at 9% of the first meetings and 3% of the second meeting. So this is having a provider come in from outside, not do a full consult, but lead a family meeting. They had no change in family anxiety or depression at 3 months. They actually saw increased PTSD amongst the family members randomized to the intervention. And I think this highlights both the importance of integrating palliative care into the ICU team and making sure that those 2 teams are working together well. But it also highlights the importance of doing research on models for trying to do this, because these are excellent investigators who came up with this intervention believing it would make things better, and lo and behold, it didn't, and may have even made things a little worse. There's another randomized trial that I'll just mention quickly on the effect of a condolence letter written by the ICU team to family members. These are data that are in press, not available yet, but are about to come out in the Journal of Intensive Care Medicine. This is Elie Azoulay's group, and they conducted a randomized trial of 240 relatives in 22 ICUs in France. They had a standardized approach to the condolence letter. The ICU team, physicians and nurses, were asked to write the letter within 3 days of the patient's death and follow a specific format that was individualized but had essential elements. And then that letter was sent 15 days after the patient's death, and relatives were surveyed at 1 and 6 months. They saw no evidence of improvement in psychological symptoms. They actually saw some evidence of worsening psychological symptoms with the condolence letter. They had worse HAD scores, Hamilton Anxiety and Depression scores, as well as worse scores on the depression component of that element. So again, something that seems like it ought to make people better didn't, and in fact may have caused a little bit increase in symptoms. We can talk about whether short-term increase in symptoms may actually be something that we need to do to help people with their long-term grief. These authors didn't really look at that, but I think that's something to think about. And then in the interest of time, I'm just going to skip through this study, but this was a randomized trial of training physicians and nurse practitioners in communication skills using the Vital Talk approach. And we actually found increased depression in the group that got in the patients of the group that got the training. I think in part because we were training residents, and particularly most of our sample was R1s, and we may have been activating them to have these discussions before they were really ready to do it. Then finally, what should our outcomes be? I think one of the things that this document does provide is it goes through the qualitative literature to identify the domains of outcomes that are important to patients and families, and then our group of experts, as well as a small group of family members, rated the importance of these, and this is also contained in the document in the electronic appendix. And I think it really shows that psychological symptoms are very important to both clinicians and family members. We also look at processes of care, and those were also important to both clinicians and family members, particularly quality of communication and family trust in clinicians. Interestingly, family members rated these even higher than clinicians did. We have some clinician-centered outcomes, things like ICU utilization, clinician self-efficacy. Those are rated a little bit lower by the clinicians, but interestingly, some of them were rated quite highly by the family members. The family members actually may care about our outcomes more than we think that they might, or more. They rate them more importantly than we do. And even things like clinician job satisfaction, quality of clinical teaching, and clinician job retention. And that, I think, highlights for me this new concept of maybe instead of the triple aim of healthcare, we should be talking about the quadruple aim. The triple aim has been articulated as working for better outcomes, lower cost, and improved patient experience. And these two authors actually propose that it should be quadruple aim, which includes improved clinician experience to make sure that we have retention in our fields and that clinicians are in a position to provide better quality care to patients and their families. So I think in terms of future directions, I think interventions should be evaluated carefully. Even things that we think make good sense may have some unintended consequences. I think there's an opportunity for integrative interventions, improving the skills of ICU clinicians around communication, giving them feedback that's specific to their ICU and is clearly actionable, and then individualizing family support tools. And I think there's also opportunities for future research on consultative interventions as well, and how to integrate those into the ICU team and make sure they have the kinds of outcomes we're looking for. In terms of outcomes, we need to work on improving the quality of our family-reported outcomes, or FROs, if you will, and make sure we're using validated and responsive patient-reported outcomes and family-reported outcomes. I think psychological symptoms have been used a lot, both because they're important, but also because they've been around for a long time, they've been well-validated, they're reliable, and they're responsive. And I think some of these newer outcome measures, which I've contributed to building, are newer and don't have the kind of experience and aren't yet as good. And therefore, we ought to really think about using single items rather than a score that includes a lot of items that may not really belong together in a score. I think if we don't have clear evidence of constructs for some of these outcomes, we ought to think about using single items. We should focus on outcomes that we can change and have a conceptual model for how we think the interventions that we're looking at are related to outcomes. And I think we need to pick our outcomes very carefully. And many studies ought to use a battery of outcomes that include both process measures and outcome measures. And with that, I will stop and thank you very much for your attention. And I think we have just a few minutes for questions if the panel wants to come up.
Hi, just a few comments. Gil Allen at the University of Vermont Medical Center. First of all, I'd like to laud the group for doing a couple things. One of them, parsing this down from 41 to 24 recommendations, and with the absence of strong recommendations based on weak evidence, unlike other guidelines that are out there. I think that helps us as leaders go back to our institution and sell these things to the believers and non-believers. We in this room are all early adopters. That's why we're here. But trying to sell this to other people, it's really, really tough. That's one of the questions is where's the evidence? So that's helpful. Randy, the other thing you said that I thought was really important is that we do have to think about clinician-centered outcomes here. This is the part that I always end my talks with back at my institution when I try and achieve buy-in. What's in it for me? Yes, I mean, physicians we care about the patient, but there has to be something in it for the people that are looking at potentially adding to their workload and maybe hopefully reducing the amount of time they're spending as opposed to increasing the amount of time they're spending. So thank you for that. My question is for Dave. So Dave, you and I had talked about this earlier about if you're involved in a research project, sometimes that helps lend some of the credibility to you when you're trying to sell this to your group. What are has anybody been looking at some of the tools for achieving buy-in at their own institutions, particularly amongst the non-believers, the people that just really are resisting this?
Okay, that's a great question. So the tools in the actual that second work tool supplement I mentioned, they're grouped by the actual recommendations, the 24 recommendations, and being as such, there's not a particular tool that's that's available that on that particular document that specifically addresses how best to achieve buy-in, which is oftentimes the elephant in the room. I think this is the difficult thing. We spent a lot of time when we were putting together a document. We reviewed the websites for multiple different professional organizations to try to come up with the work tools. We looked through SCCM's own internal website and did internal search to make sure we weren't missing tools that had come up over the years that SCCM members and groups had developed. And I'll have to be honest, did a whole process. I didn't see anything that came up that specifically regarded like a tool or some sort of prepackaged guide to help try to achieve buy-in. That doesn't mean it's not out there. I know that for example, at our institution, we're currently trying to put together a patient family advisory council, and I know that there are multiple guides that are available for doing that through the Institute of Patient and Family Centered Care, the ARC, and these sort of things. And in those guides specifically, there are sections that address organizational change and attempting to change the culture and get buy-in from folks. But that's specifically for a particular intervention. In general, I defer to other members of the group, but I'm not aware of particular tools that broadly have been trying to address that question.
I think I'd like to add to that. I think part of overcoming the naysayers is that we did not mandate these are the top 5 things, right? We left it up. We created this entire work tool so that you could build it specific to your own organization and work on the things you think you might have a possibility to change instead of beating your head against a wall with something no one's going to agree with, right? So you have the opportunity to take, this is according to change theory, that gap analysis tool was built according to change theory to facilitate change so that you look at your barriers. Do I have the autonomy to make this decision myself? Do I have the money to actually implement this resource? Are other people going to be against me if I try to do it? And then you consider these things first before you select your priorities for change. So the likelihood of overcoming the barriers is better if you talk about the barriers in group and then carefully select the first things you'd like to work on.
And I'm always a big fan of bringing data. And if you know that there's folks who haven't bought in, trying to do a meeting in some ways that's one-on-one before that to better understand what their perspectives are, what they see as the barriers. And I love bringing data. Like, help me to understand, why should I not take this data to bring to our own institution? Why do you think this doesn't apply to us? You know, and trying to do that on a personal level, I find very helpful when folks haven't bought in.
Yeah, I think it's really important to say that these recommendations, because they are made from low or very low level of evidence, we cannot mandate through regulatory standard or accreditation standard that these things must exist. They're not ready for that yet, but we are ready for movement. They are the best practices that exist out there.
I will say, as an ICU leader though, when you mandate
Yeah.
it within your own institution and because are forced to do these things, a lot of the perceived barriers do eventually start to break down with time.
Yeah. Next.
Hi, Mary Ann Barnes-Daly from Sutter Health in Northern California, and a member of the ICU Liberation work for SCCM. And as that person, I'd like to congratulate Judy and the entire team on this excellent work. When we get questions about the ABCDEF bundle, most often the questions are about the F component. And you have provided not just a set of guidelines, evidence aside, but a tool kit that teams can use, because they ask us, we don't even know how to start, and we certainly don't know how to get better. And so the gap analysis tools and tools for improvement that you provided are invaluable, and we're so happy to be collaborating with your work. Secondarily, I would like to say that your specific reference to the LGBTQI community and the inclusion of those types of specific challenges that we face is very welcomed, and I want to thank you as a representative of that cohort. My question actually is, because this type of work tends to, maybe in my own opinion, lend itself to a lot of qualitative research, and I was also happy to see that that was your first step, and that's what drove, kind of the entire process. But maybe this is a naive question, but do you find that in grading the evidence that qualitative type research does create weaker recommendations, and that your quantitative studies held more weight? Or I'm seeing some yeses and nos, so I'm interested to hear your opinions on that.
Well, we did not use we used the qualitative data to form a list of key concepts, right? And we did not you don't use the qualitative data in the grade evidence analysis. You only use the experimental literature in the grade evidence analysis. But then, once we had the recommendations that we wanted to make out of the quantitative data, we did take a step back in a few situations and, as I said earlier, see if the qualitative expressions of values matched the evidence from the quantitative data. So it was two different processes. 99% of guideline teams will start with the quantitative evidence and not look at the qualitative evidence. It's taken out of the equation. So
Right.
This use of qualitative literature is brand new. No one has done this like us before.
Right. So I guess my follow-up and the intention of my sort of rhetorical question was, maybe we do need to change the way that we create guidelines, and in areas or domains such as this, where qualitative information is so vital,
Yes.
that we may need to look at the way we grade that type of evidence differently in the formation of guidelines.
Yeah, we recommend that others use the same process we did. It was difficult for quantitative researchers to review the qualitative evidence. They needed the training in that the same way as some people needed training in how to do the evidence analysis according to grade. People who have never looked at that qualitative work really needed a little bit more guidance. So we need to probably develop qualitative evidence analysis training programs as a leadership skill within SCCM. And then we do recommend it. In fact, Randy and Maureen Coombs from New Zealand, and I and Mark Nunnally and Mary Wickline, we wrote a paper. We hope it gets accepted for publication on the use of qualitative literature and guidelines development, for hopefully so that others can replicate that process. Yeah.
Hi, Macarena from Chile. First of all, I would like to thank you. I probably say that we are just starting to build our protocol about end-of-life care and palliative care, integration of palliative care into the ICU. So I believe these kind of protocols and guidelines are an amazing tool, and you make our life much easier, at least for the ones that we like to work with families in end-of-life care. I have two questions. One of them is regards family satisfaction. We're just validating the critical care family needs inventory, and we're using the family satisfaction 24 and the quality of death and dying. So I would like to ask for the whole table, what would you use, or what is your choice when you try to evaluate family satisfaction? And the second question is for Dr. Curtis in regards to the condolence letter. What would you say, not just related to the investigations that we have, but in your experience, what would you use?
So, good questions, Macarena. So I think the problem with the family satisfaction tools is they haven't really been well validated, and it's not clear that they measure unidimensional constructs. If you want to add things up into a score and say something about the summary statistics of that score, it's very important that it be a unidimensional construct that it's measuring. Otherwise, you're adding apples and oranges, and some things may be going up, other things may be going down, and you won't be able to tease that apart. And I think the unfortunate reality is that none of our satisfaction tools or the quality of dying and death tools really meets that high standard. So I think we need future research. For now, that doesn't help you if your question to me is, okay, that's great, what do we do now? For now, I think those are the tools you mentioned are the best ones available. I think you can add them up and give a score. People have done it. There's basic reliability to doing that. But I actually believe that it's more important to pick individual items that best fit the intervention that you're trying to see, or the issues that your ICU is most concerned about, and just look at the scores on individual items. Then you don't run into that problem. And then your second question was, remind me.
Condolence letter.
Oh, yeah. So I think the findings from this study are very surprising, and I think that there are a couple of important possibilities. One is, sometimes we get it wrong. The statistics showing increased depression and anxiety suggested that with a p-value of less than 0.05, but that means that there's 5 chances in 100 that it's just plain wrong. So I think that's a possibility, but it was consistent across a couple of things, and so a couple of different scales, and so I think we have to say that it does look like that increases depression. The other thing from that study that I didn't talk about is that they looked at all of the comments that came back about the letters, and there was about a third or maybe a little more of the family members who wrote something back about the condolence letters, all positive. So, how do you put those two pieces of data together? And I think it may be that helping people work through their emotions may bring up these feelings of sadness. That may not necessarily be a bad thing. And it's one of the reasons we may need to have multiple measures in our studies.
And actually, when I was at Henry Ford Hospital as a clin spec in the MICU, we had a bereavement program, and the initial letter was handed out in a folder at time of death. And we actually, and this is what we found through feedback, that we told them we would be contacting them over the next year. So we sent a sympathy card within 2 weeks. We did a phone call at 6 weeks. We did a letter at 6 months and a letter at a year. And in our data collection, this was a quality improvement, not research, but we found that the year letter was the most significant. It got the most feedback because everybody forgot about them, and to have the unit where their loved one died. But we found that it was important to let them know we were contacting them and not to just have this thing show up. That was one of the things we discovered. On the family satisfaction, one of the things, we ran it out of our waiting room with a pink thing that went to the quality department in a lockbox, and it was handed out by our ward clerk, so it wasn't handed out by any clinician. And we grabbed Press Ganey questions, so reliable and valid questions for each of the services that functioned in the intensive care unit. We did not collate the numbers, in terms of a final score, but what we did is we looked at each group of sections to identify nursing, physician, social work, and team members, and that drove our quality improvement. So just to give you some ideas, and by the way, phenomenal work, phenomenal to have the tools to help follow through. Really just a comprehensive, stunning job.
Yeah,
Thank
and
you.
I just want to emphasize, too, about the importance of outcomes, because I think we have rather blunt outcomes for very nuanced topics. So like with that Carson study, they brought up the idea that, your loved one has chronic critical illness, the next year doesn't look good. Their outcomes don't look good. And so you have family members that maybe weren't activated, that their loved one's not doing well, and now they are activated. And so it's not maybe surprising that maybe their anxiety levels or depression levels are up when measured later. But then how do you compare that to somebody who didn't expect that outcome, and 8 months later their loved one who they thought was going to be doing great is doing horribly? How do you compare that at that time? And are we looking for the right outcomes for these very nuanced topics? And we just have these rather blunt instruments. Not that you shouldn't do it, but you have to really start thinking about, what am I measuring? What is the whole intervention? And if I'm only seeing one part of the elephant, what is this one part?
Randy, the one message I felt that that study did deliver an important message to me, and that is that these discussions about end-of-life care and goals of care are first built around the establishment of trust, and I think that if we hand that discussion off to potentially a complete stranger in day 2 or day 3 of that hospital stay, I think it could promote PTSD, because the families probably in some way feel abandoned and disenfranchised.
I do think, I agree with you, and I think that that's my interpretation of that study as well. But I think I hear people extrapolate it to palliative care consultations in general, which I think is a big mistake. And I think then bringing in an outside person who really gets to know the patient, the family, and the ICU team and works together, I think is a very different thing. Yeah.
Judy, can you speak to, because we went through a series of emails where a clinician was trying to get ICU diaries started, and they ran
to catch planes.
They ran into legal problems.
Wait.
So just to let people know that that was a discussion that a group of us had on emails, that they ran into some legal problems in starting the ICU diary.
Okay,
and
so
Judy
the ICU
was very helpful.
Yeah. We have at UCSD we have a fledgling diary program underway through the CSI, AAC and CSI program, and we had a sympathetic risk manager. Believe it or not, this woman was dropped from heaven on our doorstep, and she came and actually spoke to the nursing staff about how transparency and open acts of caring would decrease legal risk, and that she could only see as a risk manager that the diaries would help decrease litigation and not increase litigation, which is an important thing to consider in the United States. So she was right on our side. In fact, I'd farm her out to anybody who needed help, because she was really a strong supporter of the diaries and getting the staff past the fear of litigation for creating these diaries of hope and caring that are later sent home to families, and help them understand, what has happened throughout the stay. And the families really love looking day to day to see the messages that nurses write in these diaries, and because they really get it that we care about them, instead of just reading the medical record where there are no messages of hope and caring, right? It's all fact in the medical record, no hope and caring. All right, I think we've run out of time or exceeded time. I want to thank you all for coming today.